morning, everyone. It's so exciting to be here. My name is Ryan Rahman. Good morning, everyone. It's so exciting to be here. My name is Ryan Rahman. I'm a junior at Northern Highlands High School in Allendale, New Jersey, in the United States of America. I'm here today presenting my paper on bone health optimization in the perioperative spine patient and the results from a single academic institution. Perioperative means the time around surgery, specifically before, during, and after surgery. And to put my paper simply, it's about making the bone stronger before surgery in order to have a more successful surgical outcome. To understand my paper, we need to know what exactly osteoporosis means. Osteoporosis is one of the most common bone diseases of the Western world, affecting approximately 10 million people aged 50 and older. It is characterized by a slow loss in bone mass and an increase in bone fragility, making the bone more susceptible to fractures. It usually progresses very silently and is usually only diagnosed after a fracture already occurs. So common sites of osteoporotic fractures are the spine, hip, and wrist, but in my paper we'll be focusing solely on spinal fractures. The factors that contribute to osteoporosis are age, more than 50 years old, gender, female more than male, genetics such as a family history of osteoporosis, hormonal changes such as a lack of estrogen in postmenopausal women, certain medications such as long-term steroids, anti-seizure medication, proton pump inhibitors, and opioids, and lifestyle factors such as smoking, excessive alcohol consumption, and a sedentary lifestyle, as well as chronic inflammatory diseases such as rheumatoid arthritis, can all contribute to osteoporosis. So a basic understanding of normal bone physiology is essential in understanding osteoporosis. Normally there is a continuous bone remodeling happening between two very important cells, osteoclast, which is the gray cell up here, and osteoblast, which is the pink cell. Osteoclasts help in the resorption of bone by dissolving old and damaged bone tissue and taking out the dead bone, which can lead to more holes in the bone. They break the bone, so to speak. Osteoblasts, on the other hand, do the reverse and help in bone formation by creating healthy bone cells and filling up the holes made by the osteoclast, thus making the bone stronger. They help in bone formation. The uniform activity of osteoblasts and osteoclasts is the normal bone remodeling process. What happens in osteoporosis is osteoclastic activity increases more than osteoblastic activity. As you can see in the slide, the bone on the left is a normal bone, and the bone on the right is an osteoporotic bone, which has more holes and is much more hollow and much weaker. So the focus of my study is mainly on patients with osteoporosis in the spine and their management. The lumbar vertebrae are the most commonly affected area in the spine, so we'll be focusing on that area. The lumbar vertebrae are located like right here in the lower back. So let's focus on this lady's osteoporotic lumbar vertebrae. Since this lumbar vertebrae is osteoporotic, it has a significant chance for fracture, which is what happened here in this animation. These spinal vertebral fractures can affect the anterior half of the vertebral body and disrupt the anterior alignment of the spine, as you can see here in this animation. These fractures occur with minor activities such as a fall from standing height, or may even be spontaneous. One of the options for treating spinal vertebral fractures is surgical intervention, which involves instrumentation the majority of the time, which involves placing screws, rods, and plates into the bone. In this animation here, we see an osteoporotic vertebrae undergoing instrumentation. There is a high possibility it may not be successful or last very long because the bone is fragile due to osteoporosis. In my next animation here, we see a bone that has been optimized preoperatively and it's close to normal bone density, undergoing instrumentation, and it has a much higher chance of success because the bone is stronger. Our approach in this study is a multidisciplinary approach to optimize bone health in the perioperative period, which is crucial for a successful surgical outcome. Our multidisciplinary approach at a single academic center using bone liaison services to show what factors influence treatment choices during the perioperative period. We had patients referred from orthopedic surgeons and neurosurgeons to the bone health clinic. At the bone health clinic, we mainly focused on preoperative bone health optimization and post-surgical management. And at the bone liaison services, we had people of a variety of different specialties, such as social workers, pharmacists, and physicians, surgeons, physicians like endocrinologists, all came together with the common goal of bone health optimization in perioperative patients. So our methods. We looked at the patient population from different races and ethnicities at the Bone Health Clinic. More than 900 patients were seen between October 2019 and March 2021. Out of those, 204 came with spine-related issues. And then out of those, 64.7% were managed conservatively, which meant no surgical intervention was required, and they were instead managed using braces or orthosis for a period of 4 to 12 weeks. The rest of the patients, on the other hand, were managed perioperatively. So patients with the poor bone quality in the perioperative group were referred to the Bone Health Clinic. Out of the 72 patients, 4.2% had normal bone density, 29.2% had osteopenia. Osteopenia is the beginning of osteoporosis, as you can see by more holes in the bone compared to normal bone density. 44.4% had osteoporosis, and 22.2% had severe osteoporosis. Bone mass density was assessed using DEXA scans, which stands for dual energy X-ray spirometry scans, and they measure bone thickness and bone strength, and the units are the standard deviations away from the average bone density of a healthy 20-year-old. So normal bone density ranged from plus or minus 1 standard deviations away from average. Osteopenia ranged from -1 to -2.5 standard deviations from average. And osteoporosis ranged from -2.5 to -4 standard deviations from average. We also used FRAX scores, which is a fracture risk assessment tool based on the DEXA scores to calculate the chance of a fracture. So the chance of a major osteoporosis related fracture was 18.6% plus or minus 12.1%, and the chance for a hip fracture was 6.9% plus or minus 9.5%. So these are the labs that we followed in the perioperative period. So calcium and vitamin D levels are very important in bone formation and in the prevention of osteoporosis. Albumin levels is an indicator of the level of protein in your body. Parathyroid hormone, or PTH, is a very important hormone involved in calcium metabolism. P1NP, or procollagen-1 intact N-terminal propeptide, is a bone formation marker and can be used to measure rates of bone formation. CTX, or C-telepeptide, is a bone resorption marker and can be used to measure rates of bone resorption. Apart from fall prevention strategies, exercise counseling, taking vitamin D and calcium supplements, we use 2 classes of medication. Anti-resorptive medication, which prevents the bone from breaking, and anabolic medication, which actually builds the bone. So, anti-resorptive medications, like denosumab, act by reducing osteoclastic activity, as you can see here in this animation. Anabolic medications, like romosozumab, abaloparatide, and teriparatide, work by increasing the rate of bone formation, as you can see here, thus making the bone stronger. So, as you can see here in this chart, romosozumab was the most commonly prescribed medication. Romosozumab is both anabolic and anti-resorptive. It increases bone formation and to a lesser extent decreases bone resorption. The side effect profile was also minimal, with only headaches and joint pain, which is why it was the most commonly prescribed medication. The next most commonly prescribed group was the anabolics, abaloparatide and teriparatide, and the last medication prescribed was denosumab, which is an anti-resorptive medication. And these were prescribed for a period of 281 days plus or minus 192 days. We also investigated the factors influencing medication choice and found that medication contraindications played the largest role in influencing medication choice. So that means they had a condition that made it that they couldn't have a certain medication. So for example, we couldn't give bisphosphonates to patients with heartburn. We couldn't give PTH analogs to patients with poor kidney function, prior cancer therapy, or hyperparathyroidism. The next factor was patient preference, and among that, it was dosing interval. So some patients preferred monthly doses versus daily doses. Travel distance from the clinic, so how far away they were from our bone health clinic, also played a factor. And the route of administration, some patients preferred oral medication versus shots. So insurance played the last factor, and specifically insurance coverage and copay cost. So for example, some patients that were on more expensive medication like the anabolic medications, abaloparatide and teriparatide, had to switch to different medications because their insurance wouldn't cover it, or the copay was simply too high for them to afford. So this flowchart here represents a quick summary of my paper. Surgeons referred patients to the Bone Health Clinic. their bone health was assessed using DEXA scans in the labs, and based on that, we calculated the FRAX score, and that FRAX score would determine whether or not they had poor bone health or not, and most of the time they had poor bone health, which is why they were there in the first place. And then we would counsel them with fall prevention strategies, exercise counseling, the vitamin D and calcium supplements, and then we would also give them the pharmacological treatment that I've been mentioning throughout my presentation. We would administer that for a period of 3 to 6 months, reevaluate their bone health, and most of the time it would improve, and then they were taken to surgery and then managed post-surgically at the bone health. So, learning objectives of my paper. As the rates of poor bone health are continuing to rise in our aging population, and it's a severe concern in patients concerning spinal surgery, this necessitates both monitoring and treatment by a multidisciplinary team for bone health optimization. With the potential solution being bone liaison services, which help in monitoring patients with spine pathology, my paper is about describing the multidisciplinary approach to bone health optimization at a single academic institution. Thank you for your time. I'm open to questions now.
Thank you so much for your talk. It's a really interesting subject. I'm just wondering if you can kind of speak to some anticipated barriers you would see like the widespread implementation of bone liaison services, both like nationally, like in the US, and also like more internationally, like globally.
Barriers, so you mean like limitations?
Yeah, like difficulties in kind of ensuring that like all patients or more patients have access to bone liaison services before they undergo like spinal surgeries.
Okay, well, I think one of the most difficult parts about the whole thing is the amount of people that have to come together to make it possible. It's a multidisciplinary approach, so there's surgeons involved, social workers, pharmacists, and endocrinologists and other physicians. So I think the sheer amount of communication that has to happen would probably make it a significant barrier for it to happen, to make this available for everyone.
Thank you.
You might have mentioned this already, but what's the success rate difference between people who've undergone the bone optimization from the surgeries as opposed to those who haven't?
Okay, this is an ongoing study. We don't actually have the success rate right now. I'm a part of a bigger group of researchers that is doing this right now, and they let me present this study. So, but we have reason to believe that there is going to be a much more success rate because patients with osteoporosis have a 1.5 times more likely chance of a fracture. So now that we're optimizing them preoperatively and their bone health is going to normal before the fracture, there's good reason to believe that the success rate will be much higher.
So, not fresh on this field, but if I'm understanding correctly, in order to have their patient bone optimized, they have to undergo a series of treatments before the surgery. Does this mean that those patients will have their surgeries delayed? And if that's the case, I wonder, like, what are some potential implications to have the patient have this delay comparing to having the surgery directly? And also based on that, if this extra treatment and optimization is worth it.
Okay, well, we don't have the results for whether or not it's worth it, but there's a strong indicator that it is worth it. And I think you were saying about delay regarding surgery and like the cost of having medication prescribed to them before surgery rather than just going to surgery directly. If there is a cost, which might be another barrier for it, but it seems that it will definitely help because it will improve the bone health so much so that there will be less chance of a fracture. So it really comes down to cost versus performance.
You mentioned that one of the strongest factors in deciding what type of bone health optimization medication you take is like contraindications. I'm wondering, are there any ongoing studies to check for those contraindications if they're still valid contraindications, and how important do you think that is?
How important contraindications are?
Just to confirm, just like, you know, because contraindications, I assume they're like established through previous health studies, just
Yeah.
and some might be outdated. I'm wondering if that's a continuous process to check for previously established contraindications as well as newer contraindications.
I'm not aware of that process, if it's like a continuous checking to see if the contraindications are still a thing. But it's very important to make sure that we know their contraindications, and that does play a big role because we would obviously want to prescribe the anti-resorptive and anabolic medication like romosozumab, and then antibiotics, and then lastly anti-resorptive, because antibiotics and romosozumab have a higher efficacy rate. So we would only use the other medications if they had contraindications.